Good evening, everyone, and aloha. Thanks so much for joining us for today's Hawaii Pacific Health webinar focused on cervical cancer. This is the second of our series. I'd like to welcome you all. My name is Dr. Jeffrey Killeen, and I'm here to facilitate today's conversation. Welcome to those of you who are back here for the second time. 2 weeks ago, we had our breast cancer webinar, and for those of you that returned, thank you. And for those of you coming for the first time tonight, welcome. We hope this is very beneficial. This Hawaii Pacific Health webinar event is focused on cervical cancer. The topics we hope to discuss this evening include prevention and screening. We'll talk some about statistics and information specific to Hawaii in the context of cervical cancer. We'll talk about some current and cutting-edge treatments available here in Hawaii and how you can best work with our entire care team as you receive that comprehensive treatment. Before we get started, just a couple of reminders for all of our viewers. Today's webinar will be recorded. After the event is complete, the registered participants will receive a copy of the recording. The event will also be available on our social media channels and website. For those of you joining us live, please feel free to submit questions using the Q&A button, which is at the bottom of your screen. We will do our best to answer as many of these questions as we can, as we will have a Q&A portion at the latter part of the event. So let's briefly do some introductions. As I mentioned, my name is Jeffrey Killeen. I'm the director of the Oncology Service Line. I do have a lot of direct involvement in tonight's topic as I do practice in gynecologic and breast pathology. But I'd like to introduce our panel members. First is Dr. Michael Carney. Dr. Carney is a very good friend of mine. He's a COSASA endowed professor and director of gynecologic oncology for the Department of Obstetrics and Gynecology at the University of Hawaii John A. Burns School of Medicine. He performs a variety of complex pelvic surgical procedures, minimally invasive surgery, including extensive robotic surgery, and is also involved in both the chemotherapy and research aspects of cervical cancer diagnosis and treatment. Welcome, Dr. Carney. I'd also like to introduce Dr. Ann Lee Chang. Dr. Chang is a generalist chief of the University of Hawaii Department of Obstetrics and Gynecology. She has a special interest in cervical cancer prevention and holds a weekly colposcopy clinic at Kapiolani Medical Center. I've also known Dr. Chang a long time and we work together in that colposcopy clinic. So welcome, Dr. Chang. And then I'd like to introduce Sherry Rurup. Sherry received her master's degree in nurse midwifery program from the University of Illinois at Chicago. She's a licensed advanced practice nurse here in Hawaii and works closely with our team in the diagnosis and management of cervical diseases. She's been with the University of Hawaii Health Specialist since April of 2014. Welcome, Sherry. So we hope this is just going to be a kind of a conversation tonight. We're going to try to cover multiple aspects. I'm going to start out with just a few slides to give some general things. Anytime they put a pathologist in charge of things, we often end up with microscopic pictures, and I have a little, what we call gross pathology picture. By gross, I don't mean it's not pleasant, although it may not be, but that just means it's not a microscopic picture. It's actually an actual picture of something, but we'll get to that in a minute. So let's go to our first slide. And just as kind of an introduction, for those of you that are interested, what does worldwide cervical cancer incidence look like? How big of a problem is this? What you see here is a worldwide map, and the different colors correspond to different rates of cervical cancer. And I know it's small, but the dark green and greenish colors are where there's the lowest incidence. And when you get to the very dark colors, the reds and the browns, those are the very high incidence of cervical cancer. And you notice that those higher incidences are in mostly areas of the world where there is much less access to direct healthcare and access to physicians and healthcare providers. If you go back 50 years, most of this map, it would be orange, brown, and red. And that's because if you go back 50 years, cervical cancer was a major health problem all throughout the globe, not just in underdeveloped countries. Can you go to the next slide, please? I wanted to put in one slide referring a little bit back to last week. These are two graphs that show both the incidence, and by incidence, that means how much of that cancer is out there in the population, and mortality, or patients that actually die of that cancer. Notice how on the left, and we mentioned this some last week, that breast cancer incidence actually goes up. And it goes up the more we screen for it. And that's because when we screen for breast cancer, we actually find breast cancer. Notice that the mortality from breast cancer has decreased. At the same time, its incidence has gone up, although that's a relatively moderate decrease in mortality. That's very different than what we see with cervical cancer. On the right, that red line is the incidence of cervical cancer. And you can see that over the last 40 years or so, there's been just a precipitous drop in not only the mortality of cervical cancer, but also in the very incidence of cervical cancer. So in other words, when we screen for cervical cancer, we don't increase how many cases of cancer we find. We actually can decrease how many cases of cancer we find, and I'll explain why that is in a minute. But I think it's important for the public to realize that different types of cancer, in this case breast and cervix, have very different dynamics of how the screening test affects the incidence of the cancer. Okay, could you go to the next one? To bring this a little closer to home, this is just a little graph that shows the cervical cancer death rate in the state of Hawaii. And I know it's just kind of a line that's moving around, but what it basically shows is that over the last 15 years or so, the cervical cancer death rate in Hawaii has dropped. And right now it's at an average of 1.8 per 100,000 individuals. And notice in my little box there, I put that the overall national average is 2.3. So what that means is here in Hawaii, we're overall doing a very good job of cancer screening and prevention. Next one, please. To break it down a little bit more, and this is the most recent data from the Hawaii Cancer Registry, and I know that the island of Kauai is not on this picture, and that's because the data is a little bit more limited coming out of Kauai. So what it shows is Oahu, Maui, and the Big Island, and just to give you an idea of where we're seeing higher rates of cervical cancer. They're all fairly low and below the national average, but you can see the lowest being on Maui, followed by Oahu, and then the Big Island. Next picture, please. Now this is quiz time. I don't know if you know these people. We gave you the answer to the first one. These are two very important gentlemen. You've probably all heard of the one on the left, and you can reveal his name since we gave it away. This is Dr. George Papanicolau. And if you ever are interested in history and want to hear a real interesting story, just look up the history of Dr. George Papanicolau. It's actually a fascinating story. But he is the inventor of the Pap Smear. The gentleman on the right, I bet nobody knows who that is. And maybe you could show his name, but his name is Dr. Aurel Babiš. He's a Romanian pathologist who was a contemporary of Dr. Papanicolau, but obviously they couldn't tweet about each other back in the 1920s, but they were doing similar work at the same time and came to the same conclusions, but didn't really know each other. In fact, it's said that in Romania, they don't call it the Pap smear, they call it the Pap smear. But on the right, you can see what their work led to. And they're directly responsible for what's been the most successful cancer prevention test in the history of medicine, which is the dropping of cervical cancer. Okay, next one. Okay, now a couple of pictures. Here's what we're trying to avoid. This is what you're seeing now is a picture of a normal cervix. It's very smooth. Dr. Chang or Sherry or Dr. Carney could tell you very easily that's a normal looking cervix. Now, what I'm going to show you on the right is what we're trying to prevent. And you could show that real quick. And this is also a cervix that has a large kind of cauliflower mass on it. That's an advanced cervical cancer. And so the whole point is not to let this happen. And we have all the tools to do it. We still see these cases, but this used to be the norm, and now it is not. And so our goal is to try to prevent this. Okay, next one. For those of you that might want to know, well, what does this look like under the microscope? Well, on the left is a normal cervix. This is a microscopic view of what we just showed. On the right is not a big, bad cancer. This is a precursor to cancer. And this is why we do Pap smears, is because we want to find it at this stage before it turns into a cancer. Next one, please. This is the same thing again on the left, and just for your interest's sake, on the right is actually a Pap smear. The picture on the left is from a biopsy that was taken because of an abnormal Pap smear, but what we see on the right is what that Pap smear actually looks like. So that's what I look for. We try to diagnose it at that stage. We then turn it over to the clinical team, who you'll hear from tonight. They biopsy, we see something like it's on the left, and then the process goes forward. Okay, next one. This is a graph just to show about, again, the mortality death rate of cervical cancer. Notice when we get to about 2007, that nice drop turns into a flat line. So what that means is our existing tools and the way we apply them kind of reached a stalling point. We want that curve to go down to 0. And so that's why we're here tonight, is to discuss how we can get that curve to go down to 0. Okay, next one. A lot of this has to do with a discussion about the human papillomavirus. I'm sure many of you have heard of that. There are many types of human papillomavirus. At the time I made this slide, it was over 100. I think we're now up closer to 200. But these virtually cause all cases of cervical cancer. But I think we're going to go work to our panelists now. So I'd first like to go straight to Sherry Rurup. She's kind of on the front lines of this. And what I'd like to ask Sherry is, where do you see HPV into the discussions you have with patients? What kind of discussions do you have with patients? And how would you summarize the importance of the knowledge of HPV and, of course, the vaccine that we now have available to us?
So for patients to understand kind of where cervical cancer comes from, they need to understand where HPV comes from. And HPV is a sexually transmitted infection. It's actually the most common STI, or sexually transmitted infection, in the United States. And about every year we see 14 million infections. And it is believed that most everyone, if you have one sexual partner, you will have at least one strain of the virus in your lifetime. And like was mentioned before, there are over 100 different types. Some types of HPV will just cause a wart on your hand, but the types of HPV that we're screening for are the types that actually progress to cervical cancer or genital warts. So of the types that we screen for when you come in for your annual exam, we kind of determine when was your last Pap smear. A lot of people still think you get a Pap smear every year. And that's not the case. And now we actually have tools to screen specifically for HPV in certain age groups. But in addition to cervical cancer, HPV also has been shown to cause cancers in the vulva, which is kind of the outside of the vagina, inside the vagina, the penis, the anus, also head and neck type cancers like tonsils, tongue, back of the throat. So those are things that are still just getting worked out. What we focus on with women are the vulva, vagina, and cervical cancers. And we do know that 98% or almost pretty much all of the cervical cancers are caused by these HPV types. And we currently screen for about 14 types. And there is screening for women, but right now there is no screening for men. So that is the tricky part, because it is being spread often unknowingly. Good news is that you can clear the virus. So that's kind of why we don't do Pap smears every year anymore, is because now we do have a little bit more idea of how the virus works, and how often we do clear it. And usually up to 2 years you can clear it. So depending on your age, the younger you are more likely to clear it in that time frame. The tricky part is a lot of women will ask, where did I get this? Did I just get this from my new partner? Or, I've been married for 20 years. How do I now have this? And that's HPV is like that. It can lay dormant. It can take weeks, months, or even years before it will actually be either a symptom or just detected during screening. So there is really no way to tell you where you got it. If you had more than one, even if you just had one partner, if that partner had another partner, that can be where the virus came from. So that can be frustrating for patients. But like I said, good news is a lot of times this virus can be cleared. Great news is we now have a vaccine. And initially, the vaccine, when I started in my career, the vaccine was only for younger, it was approved for 9 to 26-year-olds. And ideally, you want to get it 11 to 12 is when most pediatricians are recommending it at that age before sexual initiation. So therefore, you're getting the vaccine to help prevent you from getting the infection before you actually are exposed with your first sexual partner. And but now, as of 2018, they extended that to up to age 45. So we're now offering it to a much larger population of people. And even if you've had an HPV, one strain, you still will benefit because it does cover 9 different strains. So there still is a benefit to getting that vaccine. And it is a series of 3 shots over a 6-month period. And to whatever provider you do see can order that and then kind of initiate when you need to come in for the different times over those 6 months. And once you are vaccinated, then more than 98% of people do have those antibodies, which are what your body will develop to prevent you from getting the infection if you do come into contact with it.
Okay, thank you, Sherry. So Dr. Chang, I know that the guidelines about when patients are supposed to have Pap smears has changed a lot since I first started and even since you first started. Could you explain why do they change? Kind of what's the point? And not only just the Pap smear, but all those other procedures that might be related to it when things start to be abnormal. We need you to unmute, Dr. Chang. Yeah.
Sorry, I'm just going to say one more thing about the vaccine is the HPV vaccine also helps protect against genital warts, which is they're not cancerous, but they're a nuisance. So that's another plug for the vaccine. So cervical cancer screening, we now, for people who don't have any, what we call, who don't have any immunocompromising conditions such as HIV, we will initiate those women at age 21. And we currently now screen young women who are 21 years old every 3 years up until they turn 30. And then after that, the ideal way to be tested for or screened for cervical cancer or abnormalities is every 5 years after the age of 30 with a Pap smear. And then you add on the HPV test because it's going to give you more information of is there an abnormality or not. And then we'll continue doing the screening up until the age of 65. And if all your screening's been normal, then at that point we will stop the screening. The reason is they've been looking at this all around the country and around the world, and it looks like that people are kind of ask, well, how come I can't get screened every year? And the main reason is that it's not going to make a difference if we screen you more often. And screening you more frequently can lead to additional testing. So the additional testing is, so the Pap smear itself is like you have the view of the cervix. Your women's health provider will place an instrument called a speculum inside the vagina and then take a look at the cervix and use this swab that just grabs a couple cells. And so smart people like Dr. Colleen are going to take a look at those cells, and he's going to tell you if the cells look normal or abnormal. And that's what the Pap smear does. Then we add the HPV test, and other smart people in the lab will tell you whether the HPV is present or not. If any of those cells are abnormal, that's when people go on to do additional testing. And that's when That's what we call a colposcopy, is when I will actually look at your cervix and put some solution on the cervix to see if the cells look abnormal or not. And I'll sample the areas that look abnormal to me. And that's what we call a colposcopy. It's for women who've had a Pap smear before, it's not the most painful thing in the world, but it can be uncomfortable. And the colposcopy takes longer than the Pap smear. And it's an additional procedure and additional discomfort. And so the more testing you do, the more potentially additional procedures we do, such as the colposcopy. And so when we look at data from data sets all around the country and around the world, and it looks like that the frequency that we're testing now every 3 years without an HPV test for those women who are under 30, and then every 5 years is after the age of 30, if you have the HPV test at the same time, is going to pick up precancerous lesions or abnormal cells that potentially could be cancer, and then you won't have to have any procedures or any Pap smears more frequently. Why we stop at the age of 65 is, so what happens is if you have an abnormal Pap smear or an abnormal HPV test, you can have what we call a precancerous lesion or some type of precancerous condition, which we grade into 3 different grades called CIN1, CIN2, and CIN3. And a lot of the low grade abnormalities will just go away on their own, just like the HPV. So if you have some type of small abnormality, then we can watch and wait. Or if it is a more severe abnormality like CIN3, that's when we might need to treat you, because those potentially could lead to cancer. So, but if you're age 65 and it's been normal, generally the time from an abnormal testing to the time to get an abnormality such as CIN3 to eventually develop cancer takes so long. So that's why we generally stop at age 65, because by the time you would have a condition, you would have some other condition that would probably make you more ill. Now, as we start living longer, potentially we're going to increase that, but currently age 65 is when we're going to stop the testing.
Okay, thank you, Dr. Chang. So I think the lesson of what we've heard so far is, and what I'd like to get across too, is the Pap smear is not a standalone test. It needs to be understood as part of an entire process of cervical cancer prevention that includes now vaccination, the Pap smear, HPV testing, monitoring of abnormalities, biopsies, as Dr. Chang mentioned, and also sometimes an actual excision of a lesion, all of which is meant to keep that curve that I showed going down to 0, so that the incidence of actual cancer, which then becomes a life-threatening condition, can be eliminated. But Dr. Carney, we know that we still see cases. I showed a picture of a case, and that wasn't very long ago, and it was a patient that lived in Hawaii. So could you tell us a little bit in your practice, when you see these cases, what are some of the common themes of the cases that you see that require you to come in and deal with these invasive cancers?
Well, thanks everybody, and Jeff and all the attendees. It's really a privilege to be able to talk about this topic that's near and dear to my heart and all of our hearts. You know, in GYN oncology, one of the major cancers we take care of is, in fact, cervical cancer. And, you know, if I were practicing, you know, in the mid 1900s, I would see cervical cancer as the most common cancer that I saw. In fact, it was the most common cause of cancer death for women, you know, almost in our lifetime of our grandparents. So we have come an incredibly long way, and some of the graphs and the energies of all the people before us learning how to screen, and all the people now, you know, advancing ways to prevent this cancer and prevent anybody from coming to see me at all. And that's the goal. I think the vaccine has been tremendously successful. It's introduced, in some of the Scandinavian countries that have really good records before it was available to us, and they've seen just, it's almost a trickle, the number of cervical cancers that are happening. So we are making strides, but as you said, patients do come into my office, every week with a cervix cancer, and, the common themes, I see, and we've talked about this, and it hasn't really changed. There's almost like a double camel hump of incidence for cervical cancer. I see a cohort of patients that are younger that come in with cervical cancer, but I also see a cohort of patients that are older and, between 50 and 65 that may have had this going on for a long time. We should remember that cervical cancer usually doesn't happen overnight. It usually takes years for the HPV to, incite changes in the cells, and the cells grow and other mutations occur. And then you get the precancerous changes and eventually get a cancer. And a lot of the times that process can take 5 to 10 years, not always, but 5 to 10 years. What I see is people come in and have their children, and as part of routine screening for having children, you get a Pap smear and make sure everything's fine there, and then patients are done having their kids, and then they don't go back to their provider to get a test or a smear, and then they unfortunately progress on to have a cancer that could have been detected earlier. So I think the majority of patients I see, whether it's, and unfortunately frequently from our Pacific Island neighbors, where they don't have the screening that we have here, and also here where patients don't have access or don't take that access, that's a common theme for the patients that I see that are getting cervical cancer. Now, we'd rather treat it. There's a lot of things we can do to preserve all sorts of function and minimal treatment if we get it early. If we get later, that's a whole different story.
Tell us a little bit about some of the newer techniques that we can now use for diagnosed cervical cancer if there are still concerns, say, related to future fertility. Things like that, preservation of kind of your inborn hormonal function. How is the treatment surgically of cervical cancer kind of changed over the last several years, including lymph node sampling, things like that?
Yeah, great advances have happened. Again, turning back the clock to the middle of later last century, we had someone that would show up with cervical cancer and uniformly would get a radical surgery, taking everything out, ovaries, lymph nodes, every last lymph node. A lot of these patients, may well be cured of their cancer, but in the process, they've lost fertility, they've become menopausal, and they're saddled with, quite a few potential side effects. Edema, swelling of the lower extremity occurred routinely in patients who had cervical cancer with treatment. Menopausal symptoms, and all sorts of bladder dysfunction, bowel dysfunction, just because of the radicality of the surgery. As time has progressed and we've understood this cancer better and better, some new options, relatively new, have emerged. First of all, when we have an early cancer, now we tend to stage cancer. Staging means, how far the cancer has spread, and that correlates pretty well with prognosis. So if we missed screening and we weren't able to get the vaccine and we unfortunately got a cancer, we want a cancer that's a stage 1, and that's early. That means it's limited to the cervix. And before, we would have had this radical surgery. Now we understand a little better about what we need to do to take care of that cancer and options to preserve functions, ovarian function, uterine function, and also the less radicality of the surgery. So if someone shows up at 27 years old, hasn't had a child, has an early stage 1 cancer, very early, we can actually do a large excision of the end of the cervix, make sure that there's no spread of the lymph node to something called a sentinel lymph node, where we inject the cervix and it goes to the very first lymph node, which is a draining mechanism for the whole body. And rather than taking out 30 or 40 lymph nodes, we take out 1 or 2. We find that the cancer hopefully did not spread in that patient, that we have nice wide margins. Dr. Colleen tells me hopefully there are no high-risk characteristics of what we've taken out. And lo and behold, we've preserved fertility, we've preserved ovarian function, and hopefully this patient can go on and have a child. And then we can talk about doing a more complete surgery after that. Surgery itself has changed a bit too. We used to always make a big incision on all patients with cervical cancer, and along came minimally invasive procedures where we do little pokes in the abdomen, and we're able to do surgery for very early cervical cancers very safely. The more advanced early cancers, interestingly, we did incisions, and then we did minimally invasive with robotic surgery, got people home often in the same day. But then we looked at the data, and it looked like patients that had robotic surgery for an unknown reason for moderately early cervical cancer seemed to have a little worse outcome than people that had an incision. We don't understand why. We're trying to work through that, but it's made us take a step back and do an incision to take care of that patient. But we've learned that we can do the sentinel node. We don't have to do every lymph node to determine whether this cancer has spread and is a more advanced cancer. And in most cases, we can preserve the ovaries so that the ovary can continue producing hormones, which is very important in young premenopausal women, and preserve the opportunity for fertility. Unfortunately, when the cancer is more advanced, sometimes we don't have an option for surgery. When a cancer is a stage 2, 3, or 4, beyond the cervix, in the lymph nodes, other places, surgery is not effective, because in this cancer, we have to remove the entire cancer to have a successful surgery. But if it's beyond something that I can do surgically, we look to our radiation oncology colleagues, and they can administer radiation, hopefully to try to cure that cancer. Unfortunately, in that setting, in a young person, when we give radiation, it kills the ovary as well. And for a patient, again, our 27-year-old, maybe it's a little more advanced cancer, and if they want to have children, they can turn to our reproductive endocrinology colleagues who have the ability to harvest eggs and freeze eggs and combine that with sperm in the future and do in vitro fertilization in order to achieve a pregnancy, which is tremendous advancements in and of itself. A downside to that, I might say, is that nobody's paying for that. That's a bit of an expensive thing with our cancer patients, and insurance has been terrific at covering the treatments for the cancers, but unfortunately, when it comes to fertility preservation at that very high-tech level, we're working with the legislature here in Hawaii to try to see if we can't get some appropriate coverage for those patients. Long-winded answer to a little question. I'm sure there are more.
No, that's fantastic, Dr. Carney. And thank you for your advocacy in that specific issue too of the reproductive endocrinology benefits when these patients do get to needing pretty extensive surgery and therapy. And you can, hopefully those that are on can see that, once a cancer diagnosis is made, there are still many options available. But the whole goal, again, going back to why we're here, is to make that not have to happen. We want to decrease Dr. Carney's patient volume for cervical cancer to 0. What I'd like to do then, which that means then we need people plugged into the prevention and screening arm of this, think of it as the front end of this discussion. One thing that's always caused, I know, some trouble, and this is questions are going to be for Sherry and Dr. Chang. A lot of these things start in age groups where a lot of people don't always go to their primary care doctor. A lot of times for certain cancer screenings, mammography and such, we say, well, talk to your primary care doctor about this. A lot of 20, 21, 24-year-old women don't routinely go to their primary care doctors, their family practitioners. How, Sherry, do you start to try to deal with that to make sure that patients start to understand and get plugged into a screening program with providers that really aren't what they might consider their primary care doctor?
Often I'll get a younger woman coming in for birth control. So that's a good time to start teaching and make sure they still follow up with me annually. So when they get to 21, we can start doing the Pap smears. I also tell a lot of moms who have daughters, and they'll ask me, when should they start coming? So there are some great pediatricians that will start sending me patients at a certain age, saying, okay, you need to kind of get looped in with a gynecologist who can then manage the cervical cancer screening. So a couple different outlets. Definitely we could do better outreach with education, sexual education, and also just with the vaccine. I do have some patients that I would have thought would have gotten the vaccine at 14 or 12, and their parents didn't give it to them with this thought that, oh, it's going to make them promiscuous, or it's going to make them, they're going to feel protected from this virus and want to have sex sooner. So I try to, it's great now that we can offer it to women up to age 45, so you can start talking to the vaccine to more people. So I do feel like I've been able to reach a bigger population and share vaccine information so that hopefully they're talking to their friends, they're talking to, their kids, and it's making them the vaccine out there. Because I have a lot of people, it's been around since 2006 was when it was first came out. And I still feel a lot of people don't know about it. And if their pediatricians don't really advocate for it, and there's definitely some bias there, it might just not hit their radar. And then they've already had their first sexual encounter, and the risk is already there.
Dr. Chang, I know you're involved in this same kind of struggle, and maybe talk for a little bit about, we've talked before about different ethnic groups, different communities, even in the state of Hawaii, where we seem to have overrepresented cancer cases. What are some of the challenges, and maybe what are some of the solutions to try to really impact those populations where we're seeing those advanced cancers when we have all the available tools to prevent that?
Some of the higher risk groups are, like we talked about before a little bit, are some immigrant populations where they didn't have routine screening or access to routine screening. Certain populations within the state that just haven't had access to medical care. And so part of it is getting access to insurance, having access to healthcare providers, also just reminding primary care physicians that, hey, a lot of the primary care physicians don't do women's health, and so reminding them to say, there's plenty of OBGYNs or women's health providers who are able to provide these services. Sorry, it's late in the day. You asked me a second question.
No, I think that was good. Just to add on to that, we've have a lot of our own data on where our cancer patients, especially the advanced cases, are coming from in our community, and it points to things obviously where they're not getting plugged into the screening and prevention, and it's a big challenge. There's cultural differences in some communities. There's a lot of efforts going into that, and we probably are going to have to be pretty creative in how we approach those. Let's go to, I guess, one question. We're not quite to our Q&A, but I know one question that's come up several times is what does a Pap smear do and what does it not do? Dr. Carney, could you tell us specifically about, does a Pap smear help me detect uterine cancer or endometrial cancer?
Yeah, so a Pap smear is solely for the purpose of screening for cervical cancer. It doesn't detect ovary cancer. It doesn't detect uterine cancer. It doesn't detect lung cancer, brain cancer, nose cancer. It is only cervix cancer. And it doesn't even detect that. It's just a screening test that says, hey, something is not exactly right here. We need to go to the next step to see if there is a true problem. And that's it. And that's a common question. Every once in a while, we'll get lucky, I suppose, and a Pap smear might pick up an abnormality from another part of the GYN organs, but we don't count on that. By and large, it is solely for cervical cancer. And in patients who have had their cervix removed and never had any problem with any abnormalities before, don't need to have a Pap smear ever again because there's no cervix.
Okay, thanks, Dr. Carney. And as the one that sees a lot of these Pap smears, I'd like to just echo that. The Pap smear has been an incredibly effective test, but its effectiveness lies just as much in being able to repeat it multiple times over time, because the natural history of the process of developing cervical cancer takes many years. And because the test is done at intervals, that increases the likelihood that we'll detect it. So an individual test that's negative is good, but it's not a standalone test. And we do occasionally see an endometrial cancer that on a Pap smear, but by no means should it ever be considered a screen or test for that, especially and for the public. If a Pap smear is negative, but there's other symptoms of abnormalities, whether that's bleeding or pain or something like that, a Pap smear should not be viewed as something that's negative. I must be okay. All of those things need to be explored. So we're getting very close to our Q&A, and maybe we'll just go ahead and jump to the Q&A if that's okay. So I'm going through some of these questions. Some of these are coming in live. Some of these had been sent in before. And I'll just go right to our list of some of the live questions that have come in. Here's one that says, if Pap smears are not recommended after age 65, are other screenings recommended for cervical cancer besides a Pap smear after age 65? Why don't you take that, Dr. Chang?
So long as women have had regular screening, and that's considered 3 Pap smears without an HPV test in the 10 years before you turn 65, or 2 Paps, what we call co-test, a Pap smear with an HPV test at the same time in the past 10 years, and you haven't had any abnormalities that you needed treatment for, then you do not need any additional screening. By the way, an HPV test, how you do it is they use the same Pap smear collection, and then it's just sent to the laboratory will test for the HPV from the Pap smear specimen. So it's not 2 separate collections you're taking.
Okay, here's kind of a related question that came in. This person says, I'm 68 years old and I've had normal Pap smears, but I've never had an actual HPV test. Should I get an HPV test as a baseline, or would it be okay to just stop screening?
I think it's okay to stop screening so long, like I said, is if you've had those 3 HPV tests beforehand and you've been having regular screening. It's not infrequent, though, that I do a Pap smear on someone who's 75 years old because they haven't had a Pap smear since they had a child, maybe at the age of 28, or they've never had a Pap smear before. Just to reiterate, if you've been getting regular screening, then you can stop at the age of 65. Or as Dr. Carney said, if you've had a cervix removed, then you can stop screening if you haven't had abnormalities beforehand.
Okay, here's a question that I think I would direct towards Dr. Carney, at least first. This attendant says, I completed chemotherapy and radiation therapy for breast cancer, and I'm currently on tamoxifen. I've heard that there is a link to cervical cancer and tamoxifen. Is there something other than a yearly Pap smear that I should be doing related to a potential risk of cervical cancer?
Very good question. Breast cancer is so common and so many people are taking tamoxifen, and this is a question. And it's just the question also kind of highlights how misinformation gets out into the community too. Tamoxifen does not increase your risk of cervical cancer. Tamoxifen has no relation to cervical cancer whatsoever. However, it does slightly increase your risk of another cancer. Just up the way from the cervix is the endometrium. So tamoxifen has been related to cancer about 1 out of every 1,000, 2,000 cases to an endometrial cancer. We don't screen for endometrial cancer because patients similar to a more advanced cervix, but even early endometrial cancer patients tend to have some spotting. And that would prompt anybody who's postmenopausal to immediately go see your doctor for any spotting, even if it's a brown discharge. Oh, it's not really blood, it's just brown, or it'll go away, or I'm feeling pretty young, or something like that. I feel bad. No, any bleeding, any abnormal discharge, any brown after menopause, go in and get checked. And that is, you know, if you're on tamoxifen, it could be a sign of something. Most people that have bleeding on tamoxifen, fortunately, have bleeding for other causes. But with respect to cervical cancer, it's not a risk factor for a cervix cancer.
Okay, we'll stick with you, Dr. Carney. Another question that came in is cervical cancer the same as vaginal cancer?
Good question. Cervical cancer and the vagina are both mostly made out of the same type of cells, the squamous cells. And those squamous cells tend to harbor the HPV virus. They're almost a continuum from the vagina to the cervix. Curiously, 99% of the cancers that are related to the HPV are on the cervix and not on the vagina. So it's very uncommon to have a vaginal cancer. So if you've had a hysterectomy with your cervix removed, remember, some people do get a hysterectomy and don't get their cervix removed, but if you have had your cervix removed, the likelihood of you getting a vaginal cancer is incredibly small. Here in Hawaii, I don't know the exact number, but it's single digit a year of patients that would get a vaginal cancer. So very, very uncommon.
Okay, thanks, Dr. Carney. We'll switch subjects a little bit. I think I'll ask Sherry this, and maybe Dr. Chang can chime in after Sherry. There's a question that came in, and I'll kind of summarize it. If we're typically not going to do cervical cancer screening in women over the age of 65, does that mean that I don't need to have any other kind of a pelvic examination anymore? Therefore, maybe don't need to have, as many appointments with my doctor. You're both muted, so
Sorry.
no fair staying muted.
I typically still recommend that women over 65 come in. They can do every other year, but sometimes that's insurance driven. Definitely, some insurances will only cover the well woman exam every other year after age 65. But there are still screening that I'm doing, and not just, even though I specifically take care mostly of obstetrical and gynecology patients, I have to keep some of my patients on track still with, are you doing your colorectal cancer screening? I'm also doing a good examination of the vulva and the vagina. I still have found vulva cancers on patients over age 65. We're doing a breast exam, which is also, just an additional screening tool that we can use between mammograms. So I don't tell women over 65 to abandon the visit, even though often they want to. I try to say, it's great, you don't have to do the cervical cancer screening, so it won't be as uncomfortable of a visit, but I still feel it's an important preventative part of care for women in that age group.
Could you make a comment too, Dr. Chang? Because I know a lot of us are involved, especially in screening, both from the pathology and the clinical side, as the guidelines have gotten progressively more spread out. One concern was, well, does that mean patients are not going to be coming in for other things? What is your take on that?
Oh no, I agree with Sherry. One additional thing is that it's very hard for women to examine that area around the vagina, vulva themselves, and so if there is an abnormality on the skin or even around the anus, then it's really hard for women to see that themselves. And so, and similarly, there's other, like Dr. Carney was saying, there's ovarian masses, like uterine abnormalities that you might not. It's hard to pick up unless you're having an exam. So we do try to encourage women to come in regularly, and similarly, that is not another opportunity to talk about the conditions like Sherry was talking about, and to make sure that people aren't behind on getting their mammograms and other testing.
Okay, thanks, Dr. Chang. I have a question here, and I'm going to take a little executive privilege because it's kind of a pathology question so that I get to answer it. Somebody asks, is there a difference between abnormal cell change and irregular cell change in a Pap smear? I like the way that person's thinking. Let me just talk just for a second about Pap smear diagnosis. The Pap smear is an incredibly useful test, but it has limitations and it's a challenge. There's kind of a dichotomy or whatever the word is, in that there are classic findings on a Pap smear that we know are very highly correlated with cancer precursors. And when a clinician such as Dr. Chang gets that report, she knows she has to intervene. There are other changes on a Pap smear that are not quite as definitive, but as a pathologist, I know they're abnormal. Even though they may be relatively mild compared to the classic changes, they actually have a correlation with severe precursor lesions as well. So because of that, we often have to act on abnormalities from the severe ones to those that aren't quite so severe. So what's described here might be kind of mild abnormalities, but that doesn't mean there might be a significant true abnormality. And that's what we mean by a screening test. The Pap smear is not definitively diagnosing anything. It's just trying to find a patient that needs to have further investigation to make sure that they don't have a significant lesion. So let's go to, maybe this is a good one for Dr. Chang. Do gynecologists continue to do visual screening of the cervix without doing the Pap smear during annual checkups?
I do. So when people have an annual checkup, I do a pelvic exam. So I take a look on that. I start from the outside and I look around the skin, and then I will look inside the vagina and on the cervix, because there's other things you might see, or you could have what we call a polyp, or a kind of like a skin tag, or even in those rare situations, some type of abnormal cancer or abnormal growth that wasn't picked up before. And then we do what we call a bimanual exam, where we put our fingers inside the vagina and on the other hand on the abdomen, where that way we can feel the uterus and see if there's any masses on the ovaries.
Okay, thank you, Dr. Chang. A question came in, and it's a great question. I'm going to have Sherry try to answer this, and I hopefully we have a good answer for this because it's an important subject. What about the emphasis to immunize boys? Kind of in your practices, did discussions ever come up about male immunization?
Mostly from patients that are mothers and have sons. will ask me about it. I also encourage my younger patients to ask their partners if they were vaccinated, and that if they haven't been, to encourage them to do that. Because I do think it's because the cervical cancer component is what we talk about the most. I do often get asked, well, how does it affect men or boys? And we are starting to see more data that there are these neck and throat and tongue and those cancers that are linked to HPV. And I think that the male part is definitely overlooked. So that's my best angle, is just to try to get partners to talk to their other partners and just know that it's a sexually transmitted infection, and their conversations you should be having with your partner about, do you have any, have you had testing? And it's an opportunity to hopefully get more people vaccinated.
I think early on, this was one of the drawbacks of how we initially started going for vaccination. But I think over time, and I've seen statistics from Hawaii, which are actually very good, as the male population, young males, the vaccination rates in Hawaii have picked up to pretty impressive rates. It brings in an entirely another dynamic, because we're now talking more about pediatric aged male patients. So we have to work very closely with our pediatric colleagues to push the vaccination at those ages. So we're getting close here. I'm looking for kind of a couple of questions, or a question or so. Let's see, maybe for Dr. Carney, is cervical cancer hereditary?
Oh, that's a good question. No, it's related to the HPV virus almost exclusively, and it's not a hereditary cancer, unlike so many other cancers that we look at, breast, colon. No, not related.
Can you get cervical cancer a second time if you haven't had, or what other risks of cancer do you have if you've had cervical cancer?
Well, just working backwards, we talk about the HPV virus protecting us from cervical cancer, but like Sherry said, it protects you from a lot of other cancers like anal cancer, vaginal cancer, throat cancer, head and neck, tongue. And guess what? Those are the other cancers you can get. If you get a cervical cancer, you're at higher risk for those very cancers, because their etiology, the HPV, is exactly the same. So yeah, if you've had a cervix cancer and you've had your uterus and cervix removed, you still are one of those patients that have to continue getting a Pap smear. We know you have the HPV virus. We don't really need to check for that anymore, but you do need to get surveillance, not only to look for a recurrence of that cervical cancer, but also to look for a potentially new cancer on the vulva or vagina.
Okay, thanks, Dr. Carney. Maybe this one for Dr. Chang. It might be a challenge, but we'll test you. Is the HPV vaccination less effective if you waited longer than recommended between the doses? I got my first dose at 15, but then had some problems. I fainted afterwards, so I didn't get my second dose until I was 21. What would you recommend?
So right now, for the younger population, they only need two vaccines if you're in that pediatric group a year apart. But when you are older, you need the 3 vaccines. So if you never got the recommended timing of the 2 vaccines when you were pediatric, then yep, plenty of patients, you just go back and you do your second vaccine, and 4 months later you do your 3rd vaccine. And it seems like it's pretty good. So I wouldn't be too worried.
Okay, thanks, Dr. Chang. Well, unfortunately, we've kind of come to the end of the program. We could talk about this for a long time, I know all of you, but we'd just like to thank all of our panelists. Thank you so much for taking the time out today to provide insights for all of our viewers and our patients who are watching. We hope you were able to take away some helpful information tonight to help you focus on prevention. Hopefully we picked up on some of those themes we'd like to have, which with cervical cancer is there's an incredible opportunity in the cancer world with cervical cancer, and that's to completely eliminate a cancer. We know the cause. we have a cure for it or we have a definitive preventative therapy. So we really want to try to push that curve down to zero. As you've heard throughout today's program, Hawaii Pacific Health offers comprehensive services that can support the needs of you and your family. From virtual care video to phone in to in-person visits, we're really here to keep you and your family healthier. So with that, I think we better call it a night. We wish you all the best and thank you again and hope we see you in a few weeks for the third in our series. Good night.